Welcome, everyone. Good afternoon. Happy early September. Lovely outside. Hopefully lovely inside. So give it a second here before we get started. Perfect. All right. Well, let's go ahead and get started. So again, welcome to September 8th edition of UW Project Echo Dementia. Share my screen here. One second. There we go. All right, so you can see that okay. In keeping with our fantastic series over the last 3+ years, we'll just do a quick opening notes and reminders. If it is your first time with us, we'd love to get some information about you and welcome. So we have a fantastic didactic from Stephen Supoyo, and then we've got an equally fantastic case from Carrie Rubenstein and the Geriatric Fellows, Stephen's former training grounds, and congratulations on your graduation for the second part of our program today. Couple reminders, if you would rename yourself, so it shows your first name, last name, and clinic, or you can put that in the chat, but great to have it on the screen too. Except for this morning, earlier, I would say I've mastered the art of muting my microphone when needed and unmuting when not, so it still happens. But also, if you can turn your video on, that'd be great. If you can't, understand that too, due to bandwidth or other issues. And if there are more than one of you at your site, if you could put everyone's name in the list or chat, that'd be great, just to keep track of CME and attendance. I want to advertise and cross-advertise a couple of other wonderful learning opportunities that are CME accredited. So we've got the UW Traumatic Brain Injury and Behavioral Health Echo, which complement this in the sense that they're the first and third Fridays, as are similar for geriatrics. The Psychiatry and Addictions, apropos of our didactic topic today, Thursdays, and then the Telebehavioral Health Training Series. There's also some telephone consultation opportunities for pain medications, and then the UW Telepain series. So just a few other resources if your schedule allows. A couple reminders. We have taken great care to remove all PHI from our case. We'll ask that remain vigilant about that in our discussions. Didactic. We are recording all of our sessions. They are available on our website. And we have improved our website now to be searchable and grouping topics together. We'll continue to work on that over the next year or so to make it user-friendly. And as always, we will love your input via a 1-minute post-session survey, which you'll receive. If you still need Dementia Friends wrap cards, we've got plenty, and Allison would be happy to send them to you if you want them mailed to your office or your clinic. We've got a few more didactics for this calendar year, and we are busy planning the next. So it's kind of a brief overview of what we'll be talking about for the rest of the year. And boy, you know, the cases, I was looking back through survey responses, and so many comments about how helpful the cases are in terms of sharing applied knowledge about how to manage, best treat our people and families living with Alzheimer's and other dementias and memory loss. So such a vital part of this. Appreciate everyone who's presented a case, and we'll continue to think about creative ways to make it easy on you, lift less. We are accredited for CME. We don't have any disclosures, either the planning committee or didactic presented today. Here's our hub team. Here are our spoke sites. We are up to 67 sites, I think, that needs to be updated, and about 142 providers who have participated over the last 3 years. Really just, again, wonderful representation of different provider types, all sorts of expertise, and diverse practice locations around our state. And with that, I'm going to turn it over to Stephen Supoyo. Dr. Supoyo is our former fellow at Swedish. We'll be talking about addiction treatment in patients living with dementia. So I'm going to stop sharing. And Stephen, I'm going to turn it over to you. Thank you again for being willing to talk with us, and welcome back. Nice to see you.
Yeah, it's great to see familiar faces again. I honestly was not sure how deep or superficial I should go in this subject. And honestly, I changed the title also at the last minute, as you can tell, which I'll touch on a little bit why later. I'm just curious, just to get a sense, and this is going to involve some response from the audience, how familiar people are with treating substance use in older adults. Just anyone at all feel remotely comfortable? I'm seeing a lot of head shakes in the no direction. um, okay, just that gives me a little bit of an idea because I some of it is a bit basic, and then it goes into the weeds later, so it kind of ramps up pretty quickly. But a lot of these slides, I have to thank Dr. Benjamin Hahn, who gave me a lot of his talk from UCSD Grand Rounds. So he's a specialist. He's actually also in addiction and geriatrics, both fellowship trained. I'm kind of following in his footsteps here. So many thanks to him for his help with this talk. So the learning objectives, things I want you to take away from this talk. First off is to start at the basics in terms of using non-judgmental language. And it's always complicated when I tell people I'm an addiction doctor because I always get a response from people. Whether or not someone has an addiction is a different story, right? So when they're seeing me, it's not necessarily a label that they want. So we tend to use substance use disorders. So that was my mistake in sending the title as addiction treatment because we try to move away from that word. It's loaded, it's addiction. Understand that there's a growing prevalence of substance use disorders among older adults, and then identify some possible treatment options. So there are some special considerations that go into treating someone who is older, especially in someone who has many comorbidities and possibly also cognitive impairment, which is why it's relevant to this group of people because I think I've struggled a lot in having done both fellowships, and I still struggle in the treatment of people living with dementia, their substance use. It's very, very complicated. And there is no like silver bullets, and there's no real like guidelines around it. So this is all very much like leading edge area of a field that is going to be growing very much, I think, unfortunately, dramatically in the next few years. But the takeaways basically that I want you to take from this talk is that methadone is a great treatment option for many people. In older people, it's a bit complicated. It gets more complicated as they get older. So to continue someone on that treatment it takes some special considerations. Knowing that buprenorphine is the alternative and is the preferred. There's some societies that have basically deemed that to be the case. We have not followed yet in the United States, but Canada has gone that direction. And then of course, there are many substances that we can talk about, but I'm going to be focusing on opioids and alcohol. Naltrexone is a very promising treatment for alcohol use disorder that can be very effective in older adults as well. And there are many benefits to that in people living with dementia because it doesn't require daily dosing. It exists as an injectable. So, and the last plug basically that we need more addiction people. We need more people who know addiction in the community. We need more specialists, and we need that to be integrated with geriatrics because these folks deserve a more tailored treatment than what exists currently out there. So very much basics here, right? Like substance use, it exists on a spectrum, but what makes it a disorder is when there are consequences and the consequences become increasingly severe. You know about the DSM-5 criteria, we'll get into that later. But there's definitely areas in between with problem use and risky use where an intervention can be really helpful and to keep someone from getting to that point because really you want to get ahead of it with people before, especially someone with cognitive impairments already, you want to try to get to the point where they're reducing their use early on. So honestly, at a certain point, when you're treating someone who has cognitive impairment already, you're already in a tough spot. We recognize that. So very important to consider substance use disorder as a chronic disease. And this may seem very obvious for some people, but for a lot of the field, it's a paradigm shift. It's a brain disease, um, and it's characterized. So the definition is compulsive drug seeking and harmful consequences. There can be dependence without addiction, and it involves changes in brain structure and function, and that there's limitations to this definition because it doesn't account for the external factors that are separate from the brain disease. Um, we like to really look at substance use disorder as a chronic disease similar to hypertension and diabetes. Is it insidious? Does it cut across all socioeconomic backgrounds? Can it be uncontrolled? Can it be controlled? Um, is the patient's adherence necessary? Yes. Is it lifelong? Yes. Are lifestyle changes needed? Yes, 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 yes. So just something to really like frame your head around the treatment of this is that a lot of people I think get kind of flummoxed by the disease because there just doesn't seem to be anything you can do about it because it seems to many people to be a behavioral problem or a moral problem, but really it's a biological problem as well, and not a simply social problem, even though there are many social factors that go on top of it that complicate it. And a word about the language being used. Like I said, there are consequences to the language we use, and it's mostly barriers to willingness to seek help. People really don't want to see you if you're using words like addict or clean or dirty, or even addicted. So this is some helpful language to use, and it's always good to, in everything in life, person-centered language. A person with substance use disorder is much preferred to anything else on that list. Sober, not adherent, uh, and doesn't agree. Like there's just a lot of language that is still being changed in real time in this field, even amongst the addiction medicine folks. And in fact, some people would argue that the reason why addiction medicine has been so poor recently, in recent years, is because there's so much stigma associated with it. If it weren't so stigmatized, people would seek it out more. And then in aging, so the intersection of substance use in chronic disease is very complex in older adults. It can exacerbate and cause chronic medical conditions, and older adults are much more vulnerable to these issues. Historically, people are like, is that even a thing? Like addiction in older people, aren't they? Some people would say, aren't they even like around to suffer from this? Yes, the fact is that treatment has gotten so much better that there will be increasingly an aging population living with this disease. And there's this baby boomer cohort that came to age during a period of time where drug use attitudes were shifting. And now we live in an era where marijuana and cannabis is legal. So the substance use disorder rates prevalence is expected to at least double in the coming decade in the ages of 65 and over. So it is a problem, and it is going to be a huge problem. I'll just breeze through these slides just to show you. This is data just going back to 2020, and you can imagine with the pandemic, things have really kind of taken off. And of course, sadly, the disproportionately affected are the people of color. Non-Hispanic Black men were disproportionately represented in all of these statistics, and these are all deaths. So we're not even talking morbidity, we're talking people who are no longer here because of this disease. And just more statistics to show you, this was even going back to 2012, that there's been hundreds of thousands of percent increases in the aging of people who are seeking treatments for addiction and opiate use disorders, especially in New York City. And this number is basically around 31 people per 100,000 who have been dying unintentionally of overdose deaths as of 2020. These are the substances that people were dying of. And as you can see, alcohol kind of reigns way up there along with the opioids. And then what is it that's unique about substance use in older adults? It's, as we geriatricians know, it's the multi-complexity, it's the multi-morbidities that matter. And there's this need to basically change the way that addiction is treated, to take these into account, that to take the 5 M's that we are all familiar with in age-friendly health systems. We need to make addiction treatment more age-friendly. And Dr. Han is a leader in this field, and he's done some studies looking at what geriatric conditions exist among people who are getting opioid treatment. And you can see from this graph here that in the methadone maintenance cohort, which are people getting methadone maintenance in New York City, all of the geriatric syndromes that we know of are much higher in this population. Of course, cognitive impairment being one of them. So I'm just going to breeze through these as well. Apologies for that. So what should we be doing about this, right? This is kind of the take home that I always want to get to, is what to do with this information. And the issue at hand here is that we just aren't screening. People are dying because it hasn't been caught, or that people don't consider it to be a problem. So the takeaway action items for the treatment of older adults with substance use is to screen for their disorder, then treat it, because there are evidence-based effective treatments now, and to consider what their comorbidities are and to tailor their treatment to that, because methadone and many of these other treatment options can be problematic in people who are aging. And people with cognitive impairments, it's especially hard for things like Suboxone to microdose. So there's many ways of getting onto these treatments, and a lot of them kind of require someone to be able to follow some pretty complicated instructions. So I think we all need to be on the lookout for new emerging treatments that are going to make this process a lot easier. And this applies to a lot of different populations, people living with dementia being one of them, but also pregnant women and many others. And then to consider referring to an addiction specialist, because people don't realize that addiction specialist exists, me being one of them. We're a very rare breed, sure, but we do exist. And when there's a doubt and when there's questions and uncertainty, refer. So stating the obvious here, unhealthy drug use, unhealthy alcohol use, it's pretty much across the board screen. And it's important to screen because we know that there are impacts longitudinally and down the road. I think there's this impression with alcohol specifically that it may or may not be clear that there's an impact. But thanks to the Lancet, that we all know this diagram very well now, that there are modifiable risk factors for dementia, 40% of them. And it's pretty low here. It looks like a low number, 1%. It's alcohol, but alcohol is associated with many of these other factors too, including lower levels of education, tobacco smoking, depression, all of which are risk factors for dementia. And even though the statistics, there's some conflicting epidemiological data on alcohol use and dementia linking, in some use, in heavy use, there's no doubt. So whenever someone's like, well, I thought, there was some evidence that drinking actually improves cognition or protects against dementia. Yes, that may be true. Some data definitely shows that. It's unclear. We just don't know. But in heavy use, there is no doubt it is clearly associated with all types of dementia. And it's a staggering number of people who get no screening or no questions asked of their alcohol use in the past year. This is a study done looking at how many people were even asked at all, and 25% of men and 27% of women. So there's an interesting gender discrepancy there too. And there are specific screening tools that are adapted to older adults. They're not very well known, and there's that's the problem with these, is that you have to know them to use them. And I personally, in fact, having done 2 fellowships, a geriatrics fellowship and an addiction fellowship, I still hadn't learned about this until I spoke with Dr. Ben Hahn and looked at his talk. So this goes to show that there's just a lot of room for improvement in this area. So the Michigan Alcohol Screening Test, this is a screening instrument for alcohol use disorders that is tailored and specifically for geriatric populations. There's a short form that has only 10 questions. It's more specific than CAGE because CAGE is very much not the preferred these days, but it lacks information about frequency and quantity. So I've been asked this a lot of times, like, is there really a good screening tool for geriatric populations for alcohol use disorders? And I use the answer no, but there is one here. But really, it's about asking, because this screening doesn't actually ask how much. Um, and this is just the question. These are the questions if you're curious what those asking for. And some of them are pretty interesting because one was an increase in drinking after experiencing a loss in your life. And I'm sure we've had many patients who we've heard that story for. So it's great that they include that here. And then when you feel lonely, does having a drink help? These are questions that I think are very much unique to this survey. But I think it's really important to ask how much. And this basically, if you take nothing away from this talk, it's that when you're asking about substances, you basically just have to ask. If you're experiencing discomfort and uncertainty and awkwardness around asking the question, and maybe that's none of you, but many people do, they feel that it's sort of a moral, I guess, like question of like, how much are you drinking? Is that good or bad? But really there are guidelines on how much is too much, and you just have to ask. So you have to ask exactly how much they are drinking, and then document that, because in adults over the age of 65, the numbers are different than for the younger population. There's 3 drinks on any given day and 7 drinks in a week. And these are people who are healthy and do not take medications. So how many of our patients are really, is that the case? In which case, really for many people, it's not drinking. But these are very important numbers to keep in mind. And you want to ask how much they're drinking specifically. There's another tool that is kind of the gold standard, is used in research areas. I don't think there's any clinical utility in it, but there are ways of taking into account a person's comorbidities and their alcohol use, and it's called a carrot tool. I haven't used it myself, but this may be something that an addiction specialist would be able to do if you would refer to them. Um, and you can see the questions here that it really gets into the nitty gritties of medications that cause side effects and what kinds of diseases they may have, because it does change how much someone can drink safely. And then this is the a very well-known subject in the primary care area. SBIRT is basically, it stands for brief intervention and referral to treatment. It's asking those screening questions, and then using the language is basically a way of guidance of basically suggesting and making a recommendation for someone to reduce their drinking. Because I think a lot of the situations with substance use treatment and screening is that there's this kind of extreme of basically you have a use disorder or you don't. But really, when someone doesn't have a use disorder and we screen, we go, and we write it down, and then we don't make a recommendation. That's the key. The key is that there has to be an intervention. So once you've identified someone as having moderate to heavy drinking, there needs to be more intervention. And that intervention can be as simple as saying, based on your screening responses, I think what you're using is more than is safe. And that's a very potent language and statement to use on when someone is in your office. And then there's the fact that diagnosing a substance use disorder in an older adult is just especially challenging. And it's because cognitive impairment gets in the way of this kind of self insight and awareness. They can't self monitor. So the DSM-5 criteria is not going to help you if they can't tell you, how much they've been drinking or if it's caused any issues in their life. So it's really, this is where it's really important that there needs to be collateral. Family members need to be asked. And they often engage in fewer activities, so it's just harder to know if it's really impairing their life. If they're living in a nursing home and all they do is, spend their days there and then occasionally leave and get drinks from the corner store and come back home, and they do that for years, it's really hard to pick up. And what's the answer to that? I don't have one. It's just something to consider, that tolerance and withdrawal, these are things that are very subtle and going to be hard to pick up in this older population. So now we get to treatments. How am I doing on time? Okay. This says opioid use disorder because this is honestly the use disorder that us addiction folks are much more familiar with, and honestly, there is the most promising treatment that exists. These are life changing, evidence-based treatments that are the gold standard. It's now unethical even to do a study without offering one of these options because they just work. So for those who know, you may be familiar with these, but I just briefly go through it. There's methadone, which you can only get from a federally licensed facility. It's daily observed dosing for most people when they start off. So they literally have to go to the clinic every day to pick up their dose. You can imagine the barriers for that for an older adult living with dementia is extremely high. And then there's buprenorphine, which is a partial agonist. This is so methadone is basically something that agonizes, it activates the receptors fully, so someone can overdose on it. On buprenorphine, it's a partial agonist, so it binds to the receptor, it blocks it from any other opioids that are entering the system, but it still activates it enough to treat any potential cravings or withdrawal. And it's basically very hard to overdose on unless you combine it with other substances like benzodiazepines or alcohol. So you can actually get it in any outpatient setting. And with the pandemic, the DEA has made it extremely easy to get this. You basically fill out a 1 or 2 minute quiz or even just like a form online, and you're allowed to prescribe for up to 30 patients buprenorphine. So no one can say that the barrier is too high for them to treat opioid use disorder because the barrier is extremely low, as low as it's ever been. And then there's naltrexone. This is an antagonist. So this is kind of confused for naloxone often, but it's different in that it acts the same way in that basically if you have an opioid in your system and you take it, it's going to precipitate an extreme withdrawal. So you don't want to use it in anyone who's currently using it. It's basically to preserve abstinence. Anyone can prescribe this, but really the data for it is not good in opioid use disorder. It's really actually more promising in alcohol use disorder. So I think I have it on the next slide here. I should have put it right there, but it's going to skip forward here. Basically, in alcohol use, it's an opioid receptor blocker. And the theory behind it is that it blocks the reward or reduces the reward of drinking. So it can reduce heavy drinking. So that's the clearest evidence that it has, is that it reduces how much someone drinks. So they can take it even as they're drinking heavily and in unhealthy amounts. And it will reduce their drinking usually or help with abstinence. It's contraindicated in liver impairment, but that's really severe impairment. So really a lot of people who are drinking heavily would benefit from this medication. It's an oral medicine. You take it once a day. And for people living with cognitive impairments, it exists as an injectable once a month. It can be done in the office. And it's honestly, I think, the most underappreciated medication there that exists for alcohol use disorder. I just want to stop there really briefly because I just want to make sure people have questions. If anyone has questions about those, because I kind of breezed through that very quickly, but has anyone used any of these before? In particular, I'm curious if anyone's actually heard of or used Vivitrol, which is the injectable form of naltrexone. This is why I'm so glad to be giving this talk. Thank you for giving me the soapbox. Honestly, it is, I think, really something that we should all be considering. It requires prior authorization, though, and it does require techniques and training to inject. So it's probably best to refer to someone who's done it before, but knowing that it is an option is key. And then methadone. So I actually went to the American Society of Addiction Medicine conference last year, and they had a few talks that are tailored to older populations. And one in particular was interesting because it talked about methadone maintenance. And that there are many people now who are on methadone maintenance and are aging. And it's going to be increasingly difficult for these people to maintain that because they're going to be more vulnerable to drug-drug interactions. as I mentioned before, that you have to go physically to the clinic. And it's not a primary care clinic. It's a federally designated specialty clinic to pick up their methadone, and that's going to be harder for them to get out of the house and do that. And because of their cognitive decline and their changes physiologically, the drug is basically going to start causing some consequences. And this is not talked about very often in the addiction world or in the geriatrics world. But there are long-term consequences of methadone. These are all known consequences, and I want to highlight here the sedation, neurocognitive impairment, delirium. Because I mentioned, like before, it's a full agonist. It's basically um, you could equate it with heroin, except that it's longer acting, right? You can overdose on it. It has abuse potential. There I go again. So it has risk potential of being abused, and then it's got all of these potential endocrine side effects and long-term effects. Chronic venous disease is one that's known, and opioid-induced hyperalgesia. So it's going to become less effective for them in terms of treating their pain if they are on it for pain. Um, Peripheral edema, these are things you don't want when you're aging. So Canadian guidelines have been released actually that are recommending that first line now for opioid use disorders in older adults is buprenorphine. And I will get to this in the next few slides, but it exists in many different forms. The most commonly used form is Suboxone. That's the sublingual. So it's a film or tablet that dissolves under your tongue. But if you're not treating opioid use disorder and you're treating chronic pain, or if the lines there are blurred, and you're not sure what you're treating, but you know that they have chronic pain, this is something that we've been doing. We've been switching people to Butrans, and I didn't include the um, the brand name here because I wasn't sure if I could, but everyone knows it as Butrans because it only exists as the brand name. It's a transdermal buprenorphine. It's basically 20 micrograms of buprenorphine per hour at most, and that's basically less than what you would get even from a single pill of Suboxone. So the doses that you're dealing with here are very low, and so the risks are very low in older adults. And it's basically a patch that stays on for 7 days. So in someone living with dementia, it's a lifesaver. You can treat someone's opioid dependence or opioid use disorder or chronic pain with a patch, and you don't run the risks of of other long-term opioids because as a partial agonist, you don't get the building tolerance, you don't get the severe withdrawals, and you don't get the constipation as much, and you don't get the risk of respiratory depression as much. So this is outdated. Sorry, it says that you must apply for a DAX waiver. They actually took that requirement away recently. So thanks, Dr. Hana, for this slide, but this will need to be updated. So that's a constantly changing field, as you can tell. And it basically, you can put someone on it from methadone. Switching someone from methadone to buprenorphine can be done by just putting this patch on the next time they're due for a dose. So anybody can do this. You don't need to be a specialist. You just go and look up the dose equivalences. And once you get them to a certain morphine milligram equivalent, MME, you can just slap on a patch and it's equivalent to what they were getting before. That dose is 30 milligrams of methadone, so quite low. So for people who are on higher doses, you'll need to talk to a specialist. For some people, they're just getting their round-the-clock daily opioid that they've taken for many, 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 many years. And they are starting to have problems from it, or we're starting to worry about cognitive impairment. This is a solution. So I think this is another area where we're going to be seeing a lot more use of buprenorphine in that form in older adults. But just know that the transdermal is not approved for opioid use disorder. So FDA approval and legal shenanigans. If you know that someone has an opioid use disorder, you cannot prescribe them the transdermal. You have to prescribe them Suboxone. Yes, the fun legalities. So yes, like I said, shorter half-life, safer for people with arrhythmias, dose adjustment for renal impairment, hepatotoxicity is rare, and there's low potential for overdose. The issue with Suboxone or buprenorphine is that you can precipitate withdrawal if they have opioids in their system if you use a therapeutic dose of the oral version. So putting someone on Butrans, you won't precipitate withdrawal, but basically when I say precipitated withdrawal, it's when you kick off the agonist that's already in their system. And because the buprenorphine does not activate the receptor fully the way the other one did, which includes methadone, they will experience an immediate withdrawal. And it's probably, it's been described as the worst feeling you can imagine, the worst thing you can do to someone. And unfortunately, people who are struggling with addiction and substance use disorders, it's very familiar to them. So just for some people, even just the mention of Suboxone or buprenorphine triggers them because they remember what that was like. So this requires some finesse to switch someone from a full agonist to Suboxone. But there are resources, and I want people to know that it can be done. They don't have to give it up completely. They used to be that people had to basically put themselves into withdrawal, a washout period, if you basically, before they could switch to Suboxone, and that's no longer the case. Us addiction specialists are now using a new method that involves. We don't use the word microdosing because apparently that's technically not correct, but it's low dose initiation. It's basically giving them tiny doses of Suboxone or buprenorphine every so often and allowing it to accumulate in their system so that you kind of slip it under the agonist. It's pretty cool stuff. And I talked about naltrexone, so I'll skip over those slides. And then I just want to point out that there's just so much room for improvement with what we have so far. There are these methadone clinics that exist that where people congregate and go to get their treatment, but they don't get any primary care there, or they don't get any kind of chronic disease management. We could be doing so much more with those places if they're already going there and they're stable on their opioid use treatment. Why can't we also manage their comorbidities? Because these people need that extra touch. And it's great because I think UW has a primary care clinic in one of the methadone clinics. I know that Evergreen, which is honestly, I think, should be the gold standard. But there is room for improvements in places like syringe service programs. And because a lot of this population is hard to reach, most of them are going to be legally involved or homeless or unstably housed because of just the chaos that surrounds them in their lives. So it requires some creativity in getting to these folks. Just because they have, and just because they're aging doesn't mean that they don't deserve to get these life-saving treatments and to get it in a way that is appropriate for their age and their conditions. So I think I'll stop there. These are my learning objectives. I hope that I achieved those. And I'll take any questions. How am I doing on time?
Even we've got 5 or so minutes, maybe a little bit longer for questions. Thank you so much for a wonderful. Let's see. Who has some questions? I have one if no other.
One, two, but I can wait.
No, go.
Oh, okay. Yeah, I just wanted to echo, no pun intended, the great, like the compliments, because this is really a great talk and much needed. I am more on the dementia side of things. And so sometimes I see people whose cognition declines and they are already on the oral buprenorphine. And there are some reports that if you're developing another type of dementia that's unrelated to the opioid use, that the buprenorphine itself, although I agree much better than the methadone, can exacerbate some of the cognitive symptoms too, because it's partial agonist of the same system. And so my question is, this being a chronic disorder, is there ever a time when we can consider in a long-standing case reducing or discontinuing the buprenorphine without risking this person relapsing again?
Thank you so much for that question, because that is an excellent question. And the answer is actually quite simple. The answer seems to be no. Because we just have every study that's been done that has weaned someone off of buprenorphine or their methadone maintenance treatment which are the two gold standard treatments for opioid use disorder, deaths will increase. Relapse is very common. So it's one of those benefits versus risks type of equations that you have to play in your head. And I think with buprenorphine, the risk of cognitive impairments is not known, with chronic use, but it's definitely much lower than methadone and any other opioid. So if you are running the risk of someone basically going without any kind of protection, basically, because that's what it is from a relapse or an overdose, versus taking that additional risk of a cognitive impairment over time, I think people would choose to live. And that's a tough conversation to have, and it's a tough conversation for many patients who are already on treatment, and it's one they struggle with for their whole lives. So even though the answer is so clear, crystal clear according to the data, the way that it plays out is not, because it requires a lot of motivational interviewing, partnership, reflecting, and just kind of just evaluating someone's values and what's important to them and what their risks, what they can appreciate as like worth a risk. I see a lot of hands.
Yeah. How about I think Erica's next. How about Erica?
Oh, thank you so much. And Dr. Supoyo, this is going to be a little bit of a medication question, but it's so relevant. I work in a long-term care community, and so I see a lot of people who are still in pre-contemplation phase, or they just don't want to even deal with it. But my question is about for any of you providers that are seeing people who are drinkers, who are chronic drinkers, and on CPAP machines. Who are drinking and using CPAP machines. Are you seeing any more issues with CPAP machine use and bottles on the floor and tripping up and doing like more danger around CPAP machine use? Because I actually see residents who are like getting tangled up in things, having more falls, issues like that. And I'm trying to get them to use that as an impetus to not drink and then put on their machinery and like maybe suffocate or something. But has that been something that anybody's noticed on your ends?
I'd love to hear the answer to that too from the audience. It's just such a niche thing in a way, but yet that there are hundreds, thousands, millions of people who are drinking and using their CPAPs, or not using their CPAPs. So I think you run the risk of basically them not adhering to these treatments if they have an undiagnosed or untreated alcohol use disorder. So I think basically just you identifying that as an issue is key. That has anyone even like brought that up with them? That their drinking is not only an issue for their health, but also with this important device that they need to basically avoid all these downstream effects. So yeah, sorry, I don't have an answer, but very important that you identified that issue for sure. And pre-contemplative, and sorry, just to quickly touch on that, this is where a lot of my addiction training was around motivational interviewing. And people have asked me, like, what's the similarity between addiction and geriatrics? I don't see it. Well, I see it plain as daylight. It's about values. Like, it's about what's important to the patient. If you can get to the bottom of what is important to that patient, they will go along with what is going to help them achieve that. And if basically, not having sleep apnea, untreated sleep apnea, and not, falling and breaking their hip when they're, drinking and using their CPAP machine, that's where you get to the motivation, because their motivation is not going to be because you told them so. It's going to be what is important to them. And that's where I see a lot of similarities between addiction and geriatrics. It's about what matters most. It's the most important thing.
Good. And one last question from Assad.
Hi, thank you. Thank you for a good talk. A comment first. We have all our providers in our practice. go through the waiver program, they still don't feel comfortable starting somebody on buprenorphine. And the resources in the community are very limited in terms of referrals and all that. So that's why maybe that's one reason why we don't screen everybody, because we are kind of stuck. Okay, we screen them, but what can we do about that? I'm hoping that, you know, the new providers who finish residencies now and fellowships in geriatric medicine now will feel more comfortable ordering these medications in outpatient settings. My question is, we have such a challenge admitting our patients to nursing homes, patients who are on methadone already to nursing homes. A lot of nursing homes don't accept them because of, you know, they're not sure how to get the methadone to residents. Do you have any thoughts about that, or any tips, or anyone else has some tips?
Gary is smiling because this was a pet project, or I can call it a pet peeve. I don't know what you want to call it, but this is actually a known issue to the authorities in Washington State, at least. And at the annual conference of the Addiction Medicine Society, we had hundreds, I don't exaggerate here, hundreds of people expressing similar issues. And, you know, if you know the regulatory landscape of nursing homes, you understand why they don't want to take people with a substance use problem, because it's challenging. And I have personally tried to advocate for people to try to get them into a nursing home, and it hasn't worked if they're on methadone because of that additional hurdle, which is why buprenorphine is so important, but which is why also there needs to be more of a tailoring of these treatment services to account for the unique needs of people in these facilities, and the unique needs of people who need to be in these facilities, because most of them won't even take them in the first place. So it's discrimination. We just need to call it what it is. It's discrimination against people who have a substance use disorder, and there's going to be legal consequences, but we all need to basically speak up and report whenever we see these issues crop up, because it is a Disabilities Act violation, essentially, when they refuse someone on the grounds of their substance use. But nothing's going to change until you know, someone comes after the nursing homes and makes them do it, because they're not going to take that. They're not going to take that challenge on them without help. Now, there was a talk at the conference where one methadone clinic actually successfully partnered with a specific nursing home to accept patients on methadone. And the key was a peer counselor. They hired someone with lived experience to basically go make the rounds through the facility and say hi and engage these people in a program. Basically, it was like a day program for people with opioid use disorder or a substance use disorder, and the results of that were marvelous. Like, that's all it took, was for them to hire a single person to engage with them in a way that was not judgmental, because there's stigma and judgment wherever they go, but especially in nursing homes for some reason, because it's hard to treat them. And then, sorry, one last thing. There are many, 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 many resources for getting someone started on Suboxone nowadays. I will point everyone to Quick Start, which is from the Boston Medical Center. The Boston Medical Center has an enormous addiction center that publishes like incredible resources, apps, guidelines, contacts. They just try to make it, because it's such a big issue in Boston, apparently, but again, also in Seattle. So there are many resources, and you are not alone if you have trouble. And I don't think it's a valid reason or excuse now to say that I'm not familiar with it. You can look it up, because there are many now, and the resources are really good and easy to access, and also you can ask, because these people deserve better. If they're willing to see you and they're telling you and honest about their problem, I think they deserve that we take the extra step to look up a resource for them.
What a fantastic closing point. I thank you, Stephen, for not just this presentation, but just your work in this area. There's so much left to be done. And I feel a little bit more confident that excellent people like you are doing it. So.
Thank you. Right. And I feel better that you all have heard it.
Absolutely. And, you know, we want to be respectful of your time. We'd love it if you could stick around for the case, but understand if you need to move on to the next thing. Speaking of the case, I'm gonna go ahead and share my screen. Carrie, hopefully that's okay with you that I'm driving the slides here. We made a few edits. And thank you, Dr. Rubenstein, for coming forth with such an interesting case. I'll go ahead and click through when you want me to, but I'll let you take it from here.
Yeah, thanks. Well, and as Stephen's just very recently, in my role as fellowship director, I am very proud. Thank you, Stephen. So yeah, so we have a interprofessional geriatric assessment clinic at Swedish, which is a service that we provide as part of our fellowship training program, and we have pharmacist, social worker, and doctoral student in psychology. It's a really great service, and we met somebody yesterday that I'm presenting. So this is all very fresh. And she was referred to us by another like resident physician in the Ballard Family Medicine Clinic, so a different clinic, who's just getting to know her as well. And we'd love your thoughts. Also, kind of between patients on the call is Sarah Hemphill, who was the resident who saw this patient, a family medicine resident who saw this individual with me yesterday. And so I'm going to ask her to chime in. I'm going to try to go through pretty quickly so that we can get input, because I know that our team and the primary care team, would just love other thoughts. So this is a 57-year-old woman who just 2 years ago was like living what seems to be a normal life in St. Louis, Missouri as a medical coder. We don't know like a lot about what her life was like, but we know that she loves her dog. She had a happy childhood in Washington, and she had a husband that died young of some cardiac problem. And then sometime between 1 and 2 years ago, her son and his girlfriend sort of really did her wrong, stole lots of money. I think she said $50,000, crashed her car. This caused her immense trauma and anxiety. At some point, a doctor prescribed her alprazolam. She stopped driving, she lost her job. And in May of 2023, so just 5 months ago, 4 months ago, she moved to Washington to live with her childhood friend. You can see in the bottom left, this is a person who she has known and trusted her whole life, and who has like some experience caring for older people, and said, Val, like something's not right with you. The individual, like, friend, something's not right with you. I want you to come live with me. And so she moved in with her friend and some of her friend's family members. And at this point, significant memory and thinking problems, but didn't get any kind of baseline evaluation. But in July, just a couple months later of 2023, had this acute encephalopathic event for which she has no memory of. And maybe Sarah can jump in and kind of remind us exactly what that encephalopathic event is after I finish the timeline here. She had this big workup in the hospital. There was a lot of concern because she also has some twitching and some myoclonus sort of as part of her kind of neurological exam. She had a cognitive test that was very abnormal in a test done by a speech and language pathologist, and a workup for CJD in addition to many other things. And part of that workup ended up with a positive test, and then another test was done that was negative. Currently, she's still living with her friend, being treated for depression. Most of her ADLs are intact, but she's getting a lot of help on things, and it's not clear if that help wasn't there, how she would do. She perseverates on her son's exploitation of her. We did a MOCA yesterday that was 11 out of 30. She had some clear kind of jerking movements in the upper body. She was clearly anxious as well. She had sort of this wide-based gait, but she also has this history of like severe knee arthritis, so it's not exactly sure what is causing that. And then just sort of like, who is she? She loves reading, she loves her dog Otis, and she has like, has a good community with good friends. Sarah, can you unmute if you're able to, and just like remind the group here, or tell the group here about the encephalopathic event?
Sure thing. Hey everyone, I am sorry, I'm at a computer without a good camera, and there's a few other people in here, so I apologize for the Sorry, noise. And I also just met this patient yesterday with Carrie. But from my reading of the notes and the ED note specifically, it seems like she had a sort of sudden onset, maybe psychosis. Friends found her like roaming around the house covered in her own feces. And was talking nonsensically. She has no recollection of this event happening and has not otherwise had any like psychotic symptoms or episodes like this before, and seemed to like come back to her baseline pretty soon after she was admitted without any obvious like treatment. So it's not really clear what was going on. She's notably not using any substances per her and the friends report. And I believe they did a U-Tox that was
marijuana.
negative marijuana, but otherwise like not a drinker, never has been. Yeah, so that's what I know.
Yeah, in terms of her meds, some outside some outside provider from Missouri, even in July when she was in Seattle, sent a prescription for 30 pills of alprazolam for her. She reports that she's actually not taking it. She was put on some fancy SSRI, which she couldn't pay for. And then her current doctor just put her on fluoxetine, which she just started like 5 days ago. She did have, we'll get to it on the next slide, but she had vitamin B12 deficiency and had a lab before and after that showed improvement. And yeah, why don't we go to the next slide? These are her labs for the prion disease. I, just to be honest, like don't have a lot of experience with it and didn't do a lot of research, but the patient has sort of been told she has CJD and then been told she doesn't have CJD by multiple different people. So this is a very distressing thing for her. We can go back to this if Kimmy or others want to look. You can see her cannabinoids. We had a little bit of a discussion with her about how there's a lot we don't know about cannabis in cognition, and that we neither think it's the cause of her dementia syndrome, nor is it definitely safe for her. And so there's a lot of uncertainty there. And then you can see her vitamin B12, which is pretty low. Also, probably not the cause of this significant presentation, but potentially contributing. Next slide. This is just the report from her MRI, which showed some areas of hyperintensity, probable like hemangioma, meningioma, I'm sorry, not hemangioma, but like not a lot else. Next slide. A couple images I just quickly screenshotted. Next slide. And we can go back to any of this if y'all need. Next slide. I don't think there's anything else. So really what we want to know, we want to be thinking about is sort of the differential for this. You know, she really has, we think, the syndrome of dementia, right? Like she has 2 different abnormal cognitive tests, clear decline in her function. We don't think this is necessarily related to like PTSD or anxiety, but we think they're contributing. And then she has some like neurological concerns. And so she has a general neurologist visit at the end of October. It's Swedish. I forwarded her chart to Nancy Eisenberg, our cognitive neurologist, who y'all know, because I think she needs neuropsych testing. And then Sarah did a wonderful job of, first of all, explaining what we thought was going on and all of the uncertainty, but also talking about all the other things that are important for her, including, you know, cautious medications, caution with the cannabis, social interactions, physical activity, all of the things that we do. So would love questions, but also advice if anyone has.
Well, let's go ahead and open it up to the community. Questions, comments? So Sylvia had a hand up.
Yeah, so a couple questions. I wanted to know if we know how she's taking her medications, whether there is a system in place where somebody's helping her, or she's just, you know, taking them out of the bottles.
Yeah, great question. She is living with this friend who is also a caregiver, but notably the friend goes and does her geriatric caregiving job 12 hours a day, but she gives her meds in the morning, gives her meds in the evening if she needs it. She sets it up for her, and she either sets it up for her and like checks to see if she does it, but she didn't think that. I said, well, could she do it herself? And probably not. You know, she hasn't been on a whole lot of meds. She's still not on a whole lot of meds that she's taking regularly. But her friend is watching her. And in fact, that's kind of one of the rule in pieces of her functional decline that we documented.
Thank you. And the second question kind of tied into that is, how often is she having migraines and how often is she using that sumatriptan?
That's a good question. I have to see the pharmacist. I don't know the answer to that.
The reason why I'm asking that is that she's both on fluoxetine and sumatriptan. There is a risk potentially of serotonin syndrome, especially with that myoclonus and confusion, you know. And sumatriptan is short-lived, so I don't know. That's a potential issue. And then wondering if anybody put on an EEG on her when she was in the hospital. I might have missed that.
So, okay, she has not failed the sumatriptan yet, but so that's good. But it's a great point. And serotonin syndrome is not something we would want to add to her problems here. And I think she did have an EEG. Sarah, do you remember?
Yeah, she did. I think
Yep.
it showed like diffuse nonspecific cortical dysfunction, but nothing diagnostic.
Yep. I'm looking at it now. Stephen?
Hey, do you mind putting up the slide again with the timeline? Like there was like that timeline you had. And remind me again, how long was she down for before she was found? Do we know?
I don't know, but she had problems before then. She had sort of this baseline, this problem that happened, she thinks, because of the trauma that what happened with her son. She just started having a lot more problems cognitively. And then the report is that she had this event. I don't know how long she was down, but that she is actually better kind of than the baseline for which she came after being treated with the B12. So the part of the theme of the visit was they were hoping we were going to do cognitive testing that showed she was better and no longer impacted. But we knew that she had an abnormal interview, right? And then her MoCA was clearly abnormal. And so they were really disappointed that she wasn't demonstrating significant improvement with the B12.
Well, just because depending on how long ago that event was, you did a UTOX, right? Of course, I'm going to put my addiction hat on here. And the UTOX was done, I mean, roughly, if because there's a chance that the Xanax was not, the alprazolam isn't picked up if it was long enough ago. And she's clearly been prescribed. That's, you know, the picture sounds to me like a psychoactive drug kind of, or serotonin syndrome. Something happened where she took a medicine and it totally made her, and on top of the cognitive impairment and the dementia, it's probably just put her into delirium. That's kind of the picture I'm getting. And I really can't help but wonder if with those psychoactive drugs being present, they had to play a role, I think.
Yeah, some of the big underlying question is going to be from a neurologic standpoint. Is there a neurological disease or diagnosis that's leading to some of like her gait, her myoclonus, and the cognitive impairment? Is there a Occam's razor sort of situation? Is there, can we put these things together, because or not, because she has like ongoing kind of abnormalities in those areas that are not, and she's not been taking any of the medications.
Knowing that neither of our neurologists in the audience have evaluated this person, do either want to opine?
I am the one asking too many questions today, but would there be a possibility to upload her MRI or show us her MRI in a way that doesn't disclose any HPI?
Were those shots not helpful at all, the ones I screenshotted?
I mean, it's not that they're not helpful. I would love to see her temporal lobes.
Yeah, well, let me try right now. We'll see if we can do it
Uh,
quickly.
Not if it's gonna take too much time, of course, because
That-
Dr. Heisenberg is totally gonna see that.
Chris, that's gonna make this is gonna make me need to share. I would just say, please don't zoom in to look at the name. Is that okay?
Well, I'm hesitant to, unless you can do
Okay.
a partial screen grab. I mean, we can always go back and edit it out. But that's less ideal. than-
Okay.
So I'm hesitant to do anything that's going to potentially reveal PHI.
Okay. Let's hold up on that. There was no comment that there was significant temporal lobe findings. But I thought about Louis. So, okay, can you guys teach us a little bit about CJD and interpret those labs or no? And then the second piece is what other kind of dementia would present with myoclonus potentially, or twitching. So like I think of Lewy body disease potentially, and I guess what else? I guess that would be the question.
You can't fully tell, but I'm staring at Dr. Demoto Riley right now.
I'm somewhere else on the Hollywood Squares. I will say from the as usual, Dr. Russo asked all the questions I would have asked. I was wondering about an EEG, and yeah, wondering. So the imaging, there was great screen grabs to start with. It was helpful to see there did not appear at first blush to be a lot of atrophy. However, she is young, and these neurodegenerative cases in the young can obviously present not just atypically in that they're young, but with different symptoms. It was great that she got an LP. I may recommend that she get another one, unfortunately. You could follow up on the prion tests, but it would be to look for Alzheimer's. Early onset Alzheimer's can present with myoclonus. Another question I have is the story about the son is terrible. I also wonder what really happened. And is that part of something started then? Was there a car crash and then a story has been built around it? I don't know how much you know or how much the friends know and how much they've been able to verify what was really happening.
Yeah, we asked that question to ourselves, then to them. Friends, we asked the friend, can you get any documentation of the money he stole? Like, just, is that something we could take a look at? The friend who seems, and we also thought to ourselves, is she in a safe place right now? She's definitely a vulnerable adult, even if she's 57. And we thought she was based on our, evaluation, but the friend really seemed to think this was a thing that happened and that her son was a terrible person, and they know each other for a really long time. So, but we also wondered whether there was some psychosis, that was playing a role. And that was like one of the big things that like we are working with, not enough information, and thinking about creative ways to get more information about what happened is like super important here. Interesting about the you're saying an LP for amyloid and tau.
Yeah. And then you could also resend. I think of the RT Quick as the most specific for prion, and or you can think about FDG PET scan, and I think here you could very much make the justification of FTD versus AD. I realize we're starting to run very short on time, so I didn't know if Dr. Russo wanted to chime in with anything else.
No, that would be what I would say. And then if we're doing an LP, rare things being rare, she's 57, so we have to open those gates, adding on autoimmune encephalopathy panels. And I don't know how long that EEG was placed on, but could this person potentially have had a seizure and we're just catching the tail of it and we're not seeing anything, you know? And so if I saw her in my clinic, I would definitely, and people don't like me when I say that, but stick that EEG on for 72 hours. The epileptologists will roll the eyes at me, but I do that because I need more clarification. If she had a status epilepticus or something that, or epilepsy that just came and went, you know, it's something that we need to capture. And I also agree that prion test really doesn't show signs of clear prion disease. But it shows an elevated 14.3, which is a non-specific marker of neurodegeneration. And so.
So what's the differential for that then? Other any kind of okay. Okay.
Yeah, it just shows that nerve cells are dying for whichever reason. That's how I interpret it, but I don't know if you have another quick rule. And then if you notice, and I don't know how interreliable these numbers are, but when I look at it, the tau, you know, the cutoffs for the tau protein in that prion document are like in the thousands. And of course, different laboratories have different cutoffs, but the tau in the Alzheimer's disease biomarkers has a much lower cutoff. Because in prion disease, there is massive release of tau, like just thousands of cells dying at the same time. Whereas the neurodegenerative diseases, it's important, but it's much slower. And so again, take this with a grain of salt, but that tau being in the 300s, if you did the repeat test with the Alzheimer's disease evaluation, that might be a high tau, which is in the setting of a low amyloid would confirm an Alzheimer's disease. Which, as Dr. Demoto O'Reilly is saying, it is a wild beast when it happens in a young person, and it's horrible, and it can have any sort of atypical presentation. That, you know, regarding the question of Lewy body dementia, there needs to be those 2 out of 4 things of very well-formed vivid hallucinations, Parkinsonism, you know, in which myoclonus unfortunately doesn't include, and then wild fluctuations. And sometimes the fluctuations can be as wild as almost resembling coma, you know, and acting out of dreams, which is hard to know if nobody's watching her sleep, you know, but you need 2 out of those 4. Nowadays, we can send synuclein in the CSF, but it's out of pocket and it's now costing $950 per test. And so I myself only send it if I'm convinced that there is something that could resemble Lewy body dementia. So that would be my thoughts.
So helpful. Thank you.
Yeah, these are all excellent suggestions. And Kimmy, thank you for mentioning the FDG PET. My only input was going to be, you know, with the MoCA of 11, neuropsych testing is often not super helpful because things are at the floor. So it could be, but I would be hesitant maybe to subject somebody to that, not yield much in terms of differential diagnosis.
That's really useful, Chris. Thank you.
Yeah, usually unless language is driving that low score, you know, somebody's got aphasia. Anything less than 14 tends to be kind of minimally helpful.
Very helpful. Okay. Wonderful. Thank you.
Are you willing to keep us posted with this? I realize this is a really new case.
Sure am.
Great. Thank you so much. All right. Any other, well, I hesitate. We're at 1:31. I want to be respectful of time. You can always throw it in the chat and we'll get it to Dr. Rubenstein and team. And thank you all for your comments. I'm seeing some other comments in the chat, including from Dr. Gaster about another round of free continuing education for the cognition primary care programs. Promote that. And then Allison's link to our survey. Thank you all. We will see you back on the 22nd, where we have the great good fortune of Dr. Pattison facilitating our session, I've heard. And I will be doing the didactic on capacity evaluations. So Thank you all. Have a lovely weekend. Enjoy this spectacular weather. See you next time.